Hello, everyone, and welcome to Menopause and Arthritis Support, Strategies, and Solutions. Tonight marks a milestone I am proud to celebrate with all of you, our 100th Arthritis Talk webinar. Since we launched this series, we've reached almost 500,000 people, creating a community where knowledge meets support and no one has to navigate arthritis alone. I'm Trish Barbado, President and CEO of Arthritis Society Canada, and I'm also proud to be the co-founder of the Menopause Foundation of Canada. Two things very close to my heart. Before we begin, I want to acknowledge the land that connects us. While we're joining from communities across the country, I am speaking to you from Toronto on the traditional territories of the Mississaugas of the Credit Nation, Anishinaabe, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting places home to many First Nations, Inuit, and Métis people, and I am really grateful to have the opportunity to live and work here. Joint pain is one of the most common but least talked about symptoms women experience during menopause. Tonight, we're going to change that conversation. We're going to explore the questions that many of you are asking. And while there is much more research needed on this topic, we do have answers. Tonight, we are joined by Dr. Iliana Lega, a clinician scientist with Women's College Research and Innovation Institute, whose research is advancing our understanding of this connection, and Lalitha Taylor, a registered dietitian based in Edmonton, Alberta, who will bring both professional expertise and her lived experience with rheumatoid arthritis to our discussion. Before we get started, a few quick logistics. For the best experience, we recommend viewing the webinar on a laptop or desktop computer. If you run into any technical issues, our support team is here to help. You can email us at arthritistalks@arthritis.ca. If you have a question for our presenters, you can submit it through the Q&A button at the bottom middle of your screen. We'll try to get to as many of those as possible. You can click on the chat icon in the bottom middle of the screen to access the chat and connect with other participants and our chat moderator. And if you prefer to close that, just click the X icon to exit out of that window. If you need to enable closed captioning, please click on the Show Captioning icon in your controls toolbar at the bottom of the screen. We received several questions leading up to the webinar. Many of you are experiencing similar challenges and wondering about similar solutions. We'll address the common questions first, and then we will move to a live Q&A at the end of the session. So without further ado, let's welcome our experts who will help us navigate this important topic, Dr. Lega and Lalitha Taylor. Dr. Lega, let's start at the beginning. In terms of the words menopause, perimenopause, post-menopause, can you explain and help us understand the difference?
Sure, and thank you so much for inviting me. I'm thrilled to be here. I just want to say, other than being a researcher, I'm also a clinician who provides menopause care many days of the week. And so a lot of what I'm saying also comes from my personal experience treating women through menopause. So menopause is this arbitrary time point that happens 12 months after a woman's last natural period. Prior to that time is called the perimenopause, which I'll talk a bit about more, and then it's post-menopause. What I always really like to remind people is that menopause is normal. It happens to everyone who will live long enough, and 100% of women who are born with ovaries will go through menopause. So it's natural and normal, but it can wreak a lot of havoc in terms of symptoms and changes. Average age of menopause is 51 in Canada, with the range being from 45 to 55 being the normal range of menopause. When menopause happens between age 40 and 45, that's considered early menopause. It's still within the range of normal, but it is early. And then when menopause happens prior to the age of 40, that's considered premature ovarian insufficiency and is a different entity where treatment is recommended more for health conditions and health reasons rather than symptoms, which is the case for menopause. As I mentioned, menopause is that one day after which you've been 12 months without a menstrual period, but it's really not a one-day phenomenon. Menopause is a real transition. People who have gone through menopause know that, even though once you're 1 year post period, you're officially menopausal, it's really that time prior to the last menstrual period that can be the most symptomatic and when most of the changes are happening. That period is called the perimenopause, and some refer to it as a menopause transition. During the perimenopause is really when your ovaries are slowing down, I would say. It's when they're making less estrogen, less progesterone. They're not cycling normally and regularly. And there can be multiple fluctuations in hormone and hormonal production, which leads to multiple symptoms. It also leads to a lot of patterns of bleeding that can be quite problematic, a nuisance, heavy periods, frequent periods, and all this happens in the perimenopause. In terms of symptoms of menopause, there's at least 30 recognized symptoms of menopause. So really top to bottom, there are estrogen receptors everywhere in the body, and that's why there are symptoms that really go with many different body areas and function. So the most commonly recognized symptoms of menopause and the ones most people talk about or think about or is in on TV and movies is hot flashes, night sweats. For good reason, those are very common, occurring in most women with varying degrees of severity. Brain fog, cognitive changes are also a very common sign that a symptom that occur during the perimenopause. Changes in mood, anxiety, depression, irritability. I hear a lot of women talk about rage. They suddenly feel rage in ways they never have before. Changes in libido, loss of libido, vaginal dryness, discomfort, of course, irregular periods. And joint pain is there too. So joint pain, which I'm going to talk about more, is increasingly recognized as a menopausal symptom. Still not sort of one of the classic or typical menopausal symptoms, but there is increasing research in this area and an increasing awareness that this is also a related symptom of menopause. Beyond the symptoms, beyond the change in period and ovarian function, there's also some very important health changes that happen during the menopause transition and persist into post-menopause. So one is the impact of estrogen deficiency on bone health. And so as estrogen declines and eventually is absent, there's a tremendous amount of bone that is lost because estrogen is a very important moderator of bone health. And so during the menopause transition, women lose up to 10% of their bone mass. And again, this is physiologic. It's due to the lack of estrogen, but it can certainly, and it does increase a woman's risk of fracture later on. The other less talked about and really a big area of interest of mine is the changes of estrogen deficiency on heart health. So with the declining estrogen that happens with menopause transition, there's changes in body fat. So many women describe this change of fat towards their belly, abdominal fat, even if they haven't gained weight, but especially if they've gained weight. Cholesterol levels change for the worse. So the bad cholesterol, LDL, goes up. Glucose levels actually start going up too, with women more likely to develop diabetes or prediabetes during this time. And there's changes also happening more into the blood vessels, so change in the elasticity of the blood vessel and how they dilate. All of these changes put together are all important risk factors for cardiovascular disease. So the menopause transition is increasingly recognized as a time of cardiovascular risk factor acceleration, which is a mouthful, but basically means that it's a time when many of your cardiovascular risk factors can worsen. So it's an important time to kind of take stock of them and be engaged, if wherever possible, in preventative strategies. So let's talk a bit more specifically about joint health, because I know that's why many of you are here today. So as I mentioned already, joint and muscle pains are common. And we know that from observational studies and survey studies. They're common during the menopause transition. They tend to peak around the time of the final menstrual period, so tend to be more in that perimenopausal period. And as menopause happens, they become less frequent and severe. There hasn't been a lot of research to really characterize how These pains are described, or even clinically how to assess or measure for these types of changes. But from what is known, it's a generalized ache, stiffness, or soreness. The joints that are commonly affected are the knees, hips, back, shoulder, and hands. And there's good reason to explain why this happens. So one reason is the estrogen decline. We know there are estrogen receptors on muscles, on joints, on tendons, on the whole musculoskeletal system. And when you lose that estrogen, it causes decreased ability to repair those tissues. It causes atrophy of those tissues as well, which can lead to some of these arthritic changes. Estrogen is also a very important immunomodulator, which means estrogen is involved in helping the immune system stay healthy, if you will. And so with the loss of estrogen, there's actually more inflammation. Estrogen has a dampening effect on inflammation. It's sort of an anti-inflammatory. When you lose it, there's more inflammation, which contributes to more of these inflammatory joint symptoms. And weight gain. So weight gain is a common phenomenon in perimenopause, and that also in part indirectly explains some of the increase in joint pains. Very recently, there's this term that's been coined called the musculoskeletal syndrome of menopause. And I would say it's not super well defined yet, but there's an orthopedic surgeon in the US who sort of wrote about it first, and now there's a lot of interest in really trying to characterize it. So this really tries to sort of capture all the symptoms related to menopause that affect the musculoskeletal system. So this involves the muscles. So muscle pains as well as joint pains are commonly described during this time. Muscle mass loss, sarcopenia, which has important impacts on future wellness and fragility. Bone loss, of course, and increased tendon and ligament injuries as well, which are commonly described, especially anecdotally, not reported so well systematically in the literature, but we know increasingly that there is an association with more of these injuries during the menopause transition. When it comes to menopause in women who have known arthritis, either osteoarthritis or rheumatoid arthritis, there's little that has been described properly in the literature. And I think this is actually a really exciting area of research in menopause because there's so little that has been done, but there's quite a bit of interest right now to better understand it. What we do know is that women who have known osteoarthritis or rheumatoid arthritis they may have worsening joint symptoms and more flares during the menopause transition. Anecdotally, for sure, I've seen that, and it has been reported in some observational literature. There is some confusion clinically because as I already mentioned, some of the symptoms of menopause that affect the musculoskeletal system can actually overlap with some of the symptoms of rheumatoid arthritis or osteoarthritis. And sometimes it can be clinically challenging to differentiate the two and differentiate what symptom is being caused by what, especially because we don't have good metrics or markers of how to objectively assess or quantify for menopause-related changes in the joints. And that sort of goes along with my next point, that women may feel more pain or feel more symptoms, and the sort of routine tests that would be done to assess their disease activity or x-rays or exams do not show any increased inflammation. There's also some interesting literature about the distribution of how rheumatoid arthritis, for example, is diagnosed. And certainly it's more commonly diagnosed in postmenopausal women. Of course, part of that is age because it is more common in older women, but there's thought to be an estrogen deficiency related component. Also, we know that women who have rheumatoid arthritis, those who have early menopause, so before the age of 45 and certainly earlier than that, are more likely to have a diagnosis of rheumatoid arthritis. So again, some preliminary interesting findings that certainly makes associations between menopause and arthritis. So at this point, I'm going to turn it over to Lalitha for the next part of the presentation to talk more about her personal experiences in this with these issues.
Thank you so much, Dr. Lega, and it's a pleasure to be with you all this afternoon. So I was diagnosed with rheumatoid arthritis at the age of 19, and over the past 2.5 decades, the management and my flares and symptoms have definitely ebbed and flowed. I wanted to show you guys this picture. This was less than 10 years ago. I was competing in Penticton, BC. At that time, I was racing competitively, cycling, running, strength training, and doing all activities of daily living. And then about 6 months ago, I was completely debilitated with pain. I was having inflammation, fatigue, and I couldn't do any of the things that I normally would do on a daily basis. And for me, mentally and emotionally, there was this loss of agency, this feeling of almost an out of body experience, as I felt like I didn't have control over what was going on. And it left me feeling very confused, even though I'm a registered dietitian, I have quite a bit of clinical knowledge. It was definitely an experience, and I'm still experiencing it, that, as I mentioned before, it just felt very out of body and it felt like I was losing control. And I think for many of you guys who are tuning in today, and if you've felt that feeling where you have lost agency over your body, this is where I would encourage you to start thinking about creating anchor points to ground yourself during the day and to feel like you have restored some control into your life again. And I think for me, the first anchor point was movement. Figuring out what my body was able to do when it was able to do it. So I found at 2 o'clock p.m., once I had taken my Celebrex in the morning, I was able to walk just for 10 to 15 minutes. And if you look at the picture on the slide, my knee was so swollen, my left knee. I was limping in the morning. My hands were like penguins. I couldn't turn a faucet on. I had to have help doing the dishes. It wasn't until the afternoon where I got a bit of reprieve from pain. And that's when I capitalized on doing something for my body that I felt I had control over. The second anchor point was I really ensured that I was eating regularly. And one of the reasons, not just because I'm a dietitian, but I knew that I did not want to lose muscle mass during this period of a flare. And I also knew that during this time of uncertainty and anxiety, blood sugar imbalances can worsen anxiety and mood. And so it was an opportunity for me to feed my body, to let my body know that it was safe, to get the nutrients that I needed to help lower inflammation and create building blocks for serotonin and dopamine, those important neurotransmitters to help balance my brain health. So I made it a point of not skipping meals and becoming in a deficit of nutrients. Another thing that was important to me is and I think this happens, is when we are in pain and we don't prioritize nutrition, it's easy for us to crave more of those highly processed foods because they do give us those dopamine hits and they activate pleasure zones in the brain. The last anchor point for me was ensuring that I was resting every day. And I think this is a very difficult anchor point for people to maybe wrap their heads around. But for me, it was important to acknowledge when I was tired, to nap if I needed to practice deep breathing, to bring myself out of that sympathetic, that fight or flight mode because of pain and inflammation and work and the busyness of life, and shift into parasympathetic, where I could just relax and de-stress. The last part of this was I worked with my healthcare team. This was essential. I found myself a nurse practitioner who was very knowledgeable in menopause, and she was able to help me figure out the treatment that I needed to get my hormones in balance. And I worked very closely with my rheumatologist as well. And as you can see here, getting an infusion. I ended up getting biologics to help with the inflammation, and that did improve my inflammation, but it was definitely a team effort.
That's great. Thank you both. Just wonderful. So moving into, thank you for the segue, Lalitha, into solutions and navigating menopause and arthritis, especially with the healthcare team. I wonder if we can start with you, Dr. Lega.
Sure. Sometimes when I give these talks, I feel like my first part describing menopause is so much doom and gloom, and it's always great to get to the treatment section because there's a lot that can be done to help with many of the symptoms. So the approach to menopause treatment is really to treat symptoms. As I mentioned already, menopause itself is a normal, natural transition, and it does not need to be treated, but many of the symptoms can be quite bothersome, and there are treatments for many of the symptoms. The sort of categories of treatments generally when it comes to menopause-specific treatments are hormone treatments that are systemic, meaning you have appreciable amounts of hormone levels in your blood. Non-hormonal treatments that are specifically for some of the menopausal symptoms, local hormone treatments, which are local low-dose treatments applied directly, usually to the vulva or vagina, and then lifestyle measures that you can do in conjunction or alone with these treatments. So I want to make it very clear that menopausal hormone therapy, estrogen, progesterone, is really the first line treatment for vasomotor symptoms, so those hot flashes and night sweats that are associated with menopause, and those who are younger than 60 years of age or within less than 10 years since menopause who don't have contraindications. I think it's really important to say that up front at first, because many people still don't know that. They think that hormone therapy is something that we give sometimes in very specific situations. And yes, you always have to assess the patient in front of you and make sure they don't have contraindications and they're likely to benefit, but it should be the first thing that is, or at least part of the discussion when someone presents with hot flashes and night sweats to their provider. And this is a Canadian guideline. This is a North American guideline. This is throughout the world. This is currently the treatment approach. When it comes to hormone therapy, certainly there are some women who are not candidates. Luckily, the list is relatively small to who has an absolute contraindication to hormone therapy. So this includes women who have had a personal history of breast cancer or a hormone-sensitive cancer, which is usually an endometrial cancer. But that's a personal history because I often get people referred who have had a family history of breast cancer and feel they're not a candidate because of that. And that's absolutely not a contraindication for you to be considered for hormone therapy. A personal history of heart disease, so a heart attack or stroke, is one of the real other contraindications because hormone therapy in women who have known atherosclerotic heart disease, it can worsen that. So it is a pretty strong contraindication. And then clotting history is here. I would say that's more of a relative contraindication because depending on the type of clot you've had, what other medications you're on, there's sometimes a rule for a transdermal estrogen even then. So again, always worth to have this conversation with your provider, but just so you know, there are very few contraindications, and having a rheumatological condition and inflammatory disease is not by itself a contraindication for hormone therapy. In terms of treatment duration, because the treatment is really focused on symptoms, there's no recommended treatment duration. In general, vasomotor symptoms last 5 to 7 years based on the studies we have, but in some women they can last 10 to 20 years even, unfortunately. And so really treatment needs to be individualized for the symptom that's being treated and for the duration of treatment. Some people are under the impression that you need to stop it absolutely after 5 years of treatment, and that's definitely not the case. Oh, sorry, I think I skipped too fast. So as I mentioned, hormone therapy is primarily recommended for vasomotor symptoms, hot flashes, and night sweats, and that's because it does such a good job at relieving those symptoms. It improves them by over 90%, so it's almost like a miracle treatment for those symptoms. And that's primarily the reason it should be considered. However, it has benefits beyond that as well, which I think is important to review. So it can help with sleep, especially when the sleep is due to vasomotor symptoms, so night sweats that are happening at night, waking women up. And in and of itself, some of the hormones we use can be naturally sedating, so it helps with sleep. in the right population, it can improve mood and anxiety. So women who have new mood and anxiety issues around the menopause transition, there's some evidence that they'll benefit from hormone therapy directly on their mood. So certainly that can be a secondary benefit of it. And I put a little star by aches and pains. So even in the Society of Gynecology of Canada, there's evidence that there's some benefit on hormone therapy on these MSK symptoms. So again, a potential secondary benefit of hormone therapy in women who have that symptom. It's a very good bone drug, so it's very good for osteoporosis prevention. And currently in Canada, hormone therapy is listed as a treatment option for osteoporosis in women who meet criteria for indication for hormone therapy. And it's also very, very effective at treating local symptoms of menopause as well. So many other benefits beyond hot flashes, but that's the primary reason it should be used. So when it comes to hormone therapy, usually we're talking about both an estrogen and a progestogen. So the estrogen is really the component that gives you the benefit for hot flashes, for night sweats, and for some of the other symptoms as well. But if you have a uterus, if you haven't had a hysterectomy, which these days less and less people do, then you need a progestin to protect your endometrial lining. So you need to be given both. There are some formulations that have a progestin-like component, so you won't get a direct progestin, but you still need something that's going to protect your uterus. And so when it comes to estrogen, we have oral estrogens, which you take as a pill, and transdermal estrogens, which is when the delivery is through the skin, either as a patch or a gel. In general, the transdermal estrogens are thought to be the safest estrogens that we have because it reduces the risk of clot very significantly when you administer it through the skin, and it's safer on the liver as well because it bypasses the first pass effect of the liver. Oral estrogens are excellent as well, especially for women who don't have any contraindications, but as soon as you have certain medical conditions, then usually we would prefer transdermal estrogen just because it's the safest. And then when it comes to the progestogens, most of the progestogens that have a benefit and are have evidence for protecting the endometrium are oral progestins. So when you take it as a pill, or you can have an IUD put in. So intrauterine device that has progestin on it, a Mirena, is commonly used as in our hormone therapy management. Now, there are some other combination tablets and patches, which I won't go through in detail, but they tend to be more expensive. They tend to have more synthetic hormones as part of them, but sometimes they're excellent choices depending on individuals' preferences as well as other comorbidities they may have. So bioidentical hormones. I always like to include a slide on this because I think there's a lot of misinformation when it comes to bioidentical hormones. So what does bioidentical mean? Bioidentical really means that the hormone that is in your medicine has the exact same chemical structure as a hormone your body was making previously. Otherwise, hormones, for example, that are in the birth control pill, or as I mentioned already, some of the more synthetic hormones, they tend to have extra terminals. If you remember your organic chemistry from high school, there's just different compounds and endings on the hormone, which make it have differing effects beyond what it should naturally intended to do. Bioidentical hormones also recently has really become more of a marketing term, unfortunately, even though it is a term that means something. Really, when it's out in the public, it's really referring to a product that's being marketed as somewhat better. What I think is really important for you to know is that bioidentical hormones in general do have a better safety profile. Many Health Canada approved products that I prescribe that are in guidelines are bioidentical. And so, your MD or nurse practitioner can provide these and can prescribe them, and most of us do quite regularly. Where I find there's quite a bit of confusion, and this I think is where the misinformation comes in, is that people sometimes are under the impression that they can only get a bioidentical hormone as a compounded bioidentical hormone. And a compounded bioidentical hormone is the type of hormone that's provided for you by a specialized pharmacy where they make it themselves in the pharmacy. And so they get the bioidentical hormone and then they combine it in their pharmacy and they give it to you. Either the dosing is a little bit different or they mix it with other compounds. These types of products don't have the same regulatory and safety oversight as a bioidentical hormone you get from Health Canada, like a pharmaceutical grade one. There's also no evidence that they're safer or better, and they can actually be a bit more dangerous because of the lack of regulation. And most guidelines recommend against compounded bioidentical because of that. So I hope I've clarified that because it's always something that I think is very, very important to make clear. So in terms of menopausal hormone therapy and joint symptoms, joint pain is not currently considered a primary indication to start hormone therapy. However, having said that, there are some studies, and they're not big studies, that suggest that hormone therapy can improve joint pains. But there's really haven't been any studies that have looked at the role of hormone therapy on symptoms in women who have RA or OA, so sort of like Lalitha was describing, and whether or not in that situation there's clear benefit. However, in my clinical practice, of course, guidelines are guidelines, but you really need to look at the patient in front of you. And so, in the lack of contraindications, if there's very compelling history, sometimes it's worth a trial to see if hormone therapy can have some benefit. But that's really a conversation that needs to be had directly with your providers. And currently, we don't recommend making decisions about starting hormone therapy specifically about joint pain alone. But like I said, I think it's an individual decision sometimes between the provider and the patient in front of them, just because we're lacking in a lot of research in this area right now. Very briefly, there are some non-hormonal treatment options that primarily improve hot flashes, may improve mood to a certain extent, and sleep. These are drugs that are used for other reasons usually. So certain antidepressants have some properties that are useful, gabapentin also. And there is actually a very new drug on the market now that is specifically for menopausal symptoms that's non-hormonal. It's called fezolinetant, and it works directly in the brain centers to reduce hot flashes. So they're good options for people who cannot take hormone therapy. So, and generally that's going to be a breast cancer survivor or someone who has some other contraindications and is having a lot of menopausal symptoms. But they're a little bit less effective in general, and they don't have a lot of secondary benefits. So specifically in, with regards to joint health, there really is no reason to think this would have any specific benefit with regards to that. But of course, there haven't been studies either. Lastly, I want to cover the topic of vaginal and urinary symptoms. I know this is a talk on menopause and joint health, but I think this is such an overlooked area of menopause care. Studies report that less than 10% of women have their menopausal local symptoms treated. So vaginal dryness, pain with sexual activity, urinary frequency, and urinary tract infections become very common after menopause. Most women, in fact, will have some of these symptoms, if not all. And despite other symptoms of menopause that tend to get better with time, this is one that does not. It actually tends to worsen with time if it's not treated. So the good news is, okay, bad news, the good news. So the good news is this is a very treatable, these are very treatable symptoms. And local estrogen, so in the form of either a pill, insert or a cream, and it's a much lower dose than any of the systemic ones that I mentioned before, can be used very safely with no contraindications, essentially, and for life. So this is something that should be offered to all menopausal women. But when I see women even later in life, in their 70s and 80s, even for other conditions that I may see them for, I often ask about their local symptoms. And even if they're in their 70s and 80s, I offer treatment with a local estrogen because it's that safe even in that setting. So I think it's very, very important for people to know that, yes, there are some local moisturizers that can be used for some of these symptoms, but they're not as effective only local estrogen improves and decreases the risk of urinary tract infections. And it's definitely something that you should speak to your doctor or nurse practitioner about if you have these symptoms. And that's it for me for the hormonal treatments.
Thanks, Dr. Lega. That's really great. And Lalitha, let's bring your perspective in now, and let's talk about some self-management strategies that you would recommend as you're going through menopause and managing arthritis.
Thank you so much, Trish, and thank you so much, Dr. Lega. So I mentioned this before, but eating regularly is very important, especially when you're going through an inflammatory phase of your arthritis. Again, when we consume food, nutrition actually signals the body that you are safe. You have to shift into that parasympathetic mode, which is rest and digest, in order to absorb those nutrients. So we want to make sure that we're getting that fuel in. That means around 3 meals per day, maybe a couple of snacks. We also know that we need that fuel not just to help with managing inflammation, but we also need that fuel for executive functioning, for our brain to actually make rational decisions. When we are not eating regularly and we have deficits throughout the day, that puts our body in a stress response. Our body is already in a stress response, and that can actually increase that inflammation. So I find that especially with women that I work with that are in perimenopause, there is more under-fueling that occurs. And we have to remember, without fuel, we don't have energy. And this can worsen fatigue. It can exacerbate more of that pain and even create muscle loss. And as estrogen declines in our body, we are more prone to muscle loss, especially if we have symptoms. And many of the symptoms that Dr. Lega talked about earlier can prevent us from being active to maintain that muscle mass. So eating regularly is very important. And part of those meals, when we're thinking about regular fuel, is having an anchor point of protein. So for most women, we need about 20 to 40 grams of protein at each meal. And this is very individualistic, and you can talk to your registered dietitian to figure out what your protein needs are. And we want to disperse that protein sufficiently throughout the day. That protein is going to allow us to stabilize our blood sugar. It's going to allow us to have a feeling of satiety, feelings of fullness, but it's also going to help us maintain that muscle mass. So that's very important. And I think a lot of people, when they think about protein, they think about animal protein, but it doesn't have to be that. It could be things like tofu, edamame beans. Soy, for example, is wonderful because it contains these isoflavones or phytoestrogens that mimic estrogen-like properties within our body, which can help diminish or maybe have a positive effect on lowering night sweats and hot flashes. We want to include anti-inflammatory foods in our nutrition plan, and that includes omega-3 fatty acids. As Dr. Lega mentioned, we have a greater predisposition for that LDL, that low density lipoprotein, which is one of those bad cholesterols, to go up when estrogen declines. So we want to make sure that we have foods in the diet that support lowering inflammation and lowering cholesterol. So fatty fish is great. Contains high amounts of EPA and DHA. You don't have to have things like fresh salmon, which has a higher price point. Even canned wild salmon, sardines are great, herring. Those are all awesome and economical, non-perishable sources of omega-3s. And if you don't like fish, there's always supplements that are available. I have a liquid omega-3 fatty acid supplement that I will put in my smoothie in the morning. And that's an easy way for me to get exposure to the omega-3 fatty acids. Fiber is one thing that a lot of us don't get enough of in Canada. And women especially tend to be lower in fiber, at least the women that I see in my practice. When we hit perimenopause and progesterone declines, we can often have issues with our bowels. And so what I mean by that is, gastric peristalsis slows, we might become more constipated. And so we want to make sure that we're fiber forward at our meals, and that can also help regulate our blood sugars. So things like oats, it could be green peas at a meal, chia seeds, ground flax, our beans and legumes. These are really important to consider adding as part of our meal so that we're getting the benefits of that fiber to help with bowel regularity. But we also know fiber is really important for our gut microbiota. We hear a lot about probiotics, but fiber in of itself is a prebiotic. So it actually helps to feed all of the healthy microbiota in our gut. And when we have good gut function, that can also play a role in helping to lower inflammation. Some of our fibers, for example, oats, even contain properties like beta-glucan that can help lower inflammation as well. I think this is a really important point to touch on, and that's carbohydrate. It's interesting because I read an article about perimenopausal women having a higher rate of eating disorders because they were gaining more weight in their abdominal area. And the first thing that a lot of women tend to cut out is carbohydrate. But we have to remember that when we eat carbs, that breaks down into glucose, and that is our body's primary fuel source. We need it for activity to fuel our muscles, but we also need it for our brain. Our brain requires glucose, and that's what we need for executive functioning. If we don't include carbohydrate and keep our blood sugar levels stable throughout the day, that can create, again, this place of scarcity and deficit, and we may actually end up overeating or even binge eating on those simple carbs later on in the afternoon or evening. And that's probably one of the biggest things that I see when I'm working with women is underfueling during the day, especially with carbs, and then overeating in the evening with carbohydrate. Another really important thing to think about when we're comprising our meals is grabbing a handful of color. So notice I said color and not vegetables, fruit. I want you to think color, I want you to think vibrancy, and I want you to just think about a handful and adding that to your meals to give you exposure to antioxidants that are going to help lower inflammation and reduce oxidative stress. And I think a lot of people feel like nutrition has to be perfect. I will grab just a handful of blueberries and I'll add it to my dinner plate if I don't feel like having vegetables. Great. I will grab a handful of sugar snap peas and add it to my lunch meal. It doesn't have to be anything that is prepared or perfect. Make it simple and accessible. Now, one of the things that I want to bring to your attention is there's a lot of noise and information now, I would say, in the menopause world. And you do need to be aware of where you're getting information about nutrition. I would say a big red flag is if you come across an overly restrictive nutrition plan where you're eliminating foods, eliminating carbs, maybe even eliminating certain fruits, your spidey senses should come up. Also, too, we want to be leery of individuals who are pushing supplement-heavy protocols. So oftentimes when somebody's pushing a supplement, it's for financial gain, even if that person does have credentials behind their name. So if they're making money off of it, that's a big red flag. So you always want to talk to your pharmacist, your doctor, your nurse practitioner, even your registered dietitian about supplements, because it's definitely not a one size fits all. And I just wanted to make mention of this picture here, and I forgot to do that in the first slide. So after working with my nurse practitioner and my rheumatologist, I was able to come out of my flare and I was able to actually hike a mountain in Canmore, Alberta, about 4 months later. So again, it started with walking 10 to 15 minutes a day, and then it ended up with me regaining some ability in my joints and hiking a mountain. So there's hope. Now, I think this is a really important point for us to talk about, and that is alcohol. When we think about our lives midlife and beyond, we don't have little stressors, we have big stressors that are going on. Many of us may have marital issues. We're going through separations, divorces. Maybe we are taking care of aging parents, or maybe we've lost loved ones. This is a time in our life where there is a lot of stress. I know for me, I could be an empty nester next year with my daughter going to university. So a lot of big transitions are happening right now. And when we think about stress, our brain is always going to follow the path of least resistance to offload stress. And alcohol can be one of those coping mechanisms that people turn to. When we have alcohol, it can, solicit a calming effect. But one of the things that we know about alcohol is that it can disrupt that neurotransmitter balance. It can worsen anxiety. It can exacerbate issues with mood. So we want to be very careful about that. We also know it can worsen your architecture, your sleep architecture. It will disrupt your REM, which is your rapid eye movement, one of the stages of sleep that is really important for memory consolidation. And as we go through perimenopause or post-menopause, there can be issues with brain fog. So alcohol can exacerbate that. And we also know when we have alcohol on board, it can also affect inflammation. It can lead to nutrient deficiencies as well. So you want to choose wisely and think about some of the effects that alcohol may have in your life. There's so many different options now that are alcohol-free that you may want to consider. I know for me, going through perimenopause, having hot flashes and night sweats, alcohol has just been something that's off the table for me, because another thing alcohol can do, it can increase vasodilation of your blood vessels, which again can contribute to more of those night sweats and hot flashes.
Lalitha, sorry, I'm just wondering if we can, try just to get some more questions in, if we can just maybe go quickly through the next couple.
Sure. And so I think one of the biggest symptoms that a lot of people experience is sleep. So just to ask yourself that question, are you getting 7 to 8 hours of quality sleep? And if you're not, you need to talk with your nurse practitioner, your doctor, maybe even a psychologist to really help manage what's going on with that aspect of your life. Stress management, and I'll keep this really short, and I'm going to just maybe skip to the last point here, and that's saying no. And I think that's really important to figure out how to establish boundaries so that you can really prioritize self-care. And that self-care can look like walking, it can look like strength training, it can look like meditation. And I think if you need help with establishing boundaries, that's where maybe you need to develop a relationship with a psychologist that you can trust to help in that area.
Wonderful. That's great. Well, thank you both. What I want to do is try and get to as many questions as we can. We have loads of questions that have come in, so we'll try and do this kind of rapid fire. So I'll start with you, Dr. Lega. Tell us about being on biologics and hormone replacement. Is it safe?
So to my knowledge, I don't use biologics in my practice. There shouldn't be a contraindication. So it's definitely worth having a conversation with a provider, but I don't think there should be an issue.
Great. And I'm going to ask you another one just around age. So is it too late for someone who's 60 or 61? Are those rules hard and fast? What can people do if they're older, they're still experiencing symptoms?
For sure. So those are guidelines. So certainly if a woman is still having symptoms and she's in her 60s, then it's a risk assessment. The biggest risk is cardiac risk at that point. And so usually I do a personalized risk assessment, which may involve other cardiac testing to make sure they're low risk from a cardiac point of view. But it's not an absolute no.
Great. Wonderful. Okay, Lalitha, we have questions about intermittent fasting, good or bad for menopause and arthritis?
I think that's a really good question. And oftentimes I respond with, you can do a fast, and it's an easier fast if you can sleep through it. So one of the suggestions I make for my females especially is consider fasting after dinner and then eating maybe it's 7 o'clock that you start your fast, if that's when dinner ends, and then break your fast at 7 o'clock in the morning. I think that's easier from a lifestyle perspective. You're still getting the benefits of what you would get from intermittent fasting, but it allows you to get energy in the morning when you fast that way, and it gives you energy again for executive functioning for your brain and for you to have energy for your daily activities. So my recommendation for most women is I don't actually recommend intermittent fasting. It is a nuanced conversation, but if you want to fast, I would challenge you to consider switching the schedule.
Great. That's great. Dr. Lega, in terms of the connection between kind of joint pain and arthritis, and then also getting treatment. So many people have a hard time, as you know, many physicians are either not confident or not educated on hormone therapy. And how do women advocate for themselves? What do you recommend they do if they're having trouble getting the kind of treatment they want?
Yeah, it's tricky. So I think a lot of the work that Menopause Chicks is doing, and even the Menopause Foundation of Canada, is so important. I think coming to your appointment prepared with information and presenting that to your physician in a way that engages them in a conversation, not telling them what you think they should do, because people don't like that in general. But coming with information that, oh, I heard a talk about menopause and arthritis, and there was some evidence, maybe, do you think this is something that could work for me? And getting the language. So I think that is key. I've had patients who come to me telling me that they went to see their primary care provider, who at first said, oh, I don't really feel comfortable. And they said, you know what, this is a symptom that's really bothering me. Do you think you could look into it and I could come back in a week? And they did. And at that visit, they were able to have a conversation about hormone therapy. So that's obviously not going to work for everybody because it depends on your provider. But I think that's definitely the first step and the start. I think also then researching, menopause providers that you could then be referred to if they're not willing or able to help you is another step as well. But yes, it's unfortunate that patients have to advocate so strongly for themselves in this space, but I think it's working. I tell patients that too. I think you are helping move forward the needle, and the fact that we are talking so much about menopause, even in the medical community, is because patients are demanding it from their providers, as they should.
That's great. Lalitha, we have questions about supplements, in particular vitamin D, but I wonder if more broadly you could just say something about that area for us.
Yeah, I think most of us in Canada would probably benefit from a vitamin D supplement. But again, that's where really, if you needed to know, you could get your blood work done to test your levels. But I would say supplements, just like hormone therapy treatment, is a nuanced conversation where you need to speak to, your registered dietitian and figure out, what am I taking in and what am I missing that maybe I need to supplement with. I mean, many women that I work with in perimenopause probably do benefit from omega-3s. Many of them benefit from vitamin D. A lot of them benefit from calcium, but calcium's tricky too. The amount that we take, we don't want to over supplement with calcium. So this is where it's important to have those conversations that are individualized and specific to you, so that we can create a plan that's meaningful and not just a one size cookie cutter approach. And I would also encourage people, if they're on supplements, to go see their pharmacist to make sure they're taking them at the right time and they're not contraindicated with their other medications.
Great advice. Dr. Lega, I wanted to ask about, we have a couple of questions here sort of around the connection between going into menopause early, and is there a connection between that and then arthritis, getting that more severely, or not being on estrogen and their arthritis worsens over time. So is there any connection between that estrogen loss and arthritis? I'm not sure if this was osteoarthritis or
right,
but
I mean, in general, yes, based on what we know, because there are estrogen receptors everywhere, including on the joints, estrogen deficiency will affect your joint health, especially if you have an underlying rheumatological condition. I think what's important is that, for example, there was some mention there of early menopause or premature menopause. Like if you have a condition that predisposes you, let's say, to developing RA or OA, then it's so important that you treat that condition irrespective, right? Because part of the reason why you treat the underlying condition, let's say premature ovarian insufficiency, is to prevent some diseases of aging. And then if you also have another concomitant disease, you also need to treat that one. Sure, there's going to be overlap, but currently in at least the menopause arthritis space, there's not a lot of evidence driving that overlap. So you want to treat your two conditions simultaneously.
Yeah, okay, that's great. And Lalitha, how about things like creatine, which is getting a lot of attention lately? Any comments on creatine?
Yeah, so one of the things that creatine does, it helps to essentially allow us to produce more energy within the muscle cell, and that can enable us to recover faster, and it can also help us to grow and maintain muscle. Again, this is not a one-size-fits-all type of recommendation. I think you need to talk to your dietitian on whether or not you need to take creatine, whether you have a strength training program, or whether you're feeling like you're losing muscle mass. If you're having impaired kidney function, it may not be something that's appropriate for you. So again, you have to have these conversations to see whether or not this is a supplement that you would benefit from a muscle perspective. There's also some research coming out in terms of creatine maybe being beneficial for cognitive function, because of course we utilize energy in the brain. So I know some people have been, for example, using creatine monohydrate to help with maybe the prevention of brain fog, right? So again, I think more research will be coming out in regards to more recommendations regarding creatine. But again, this is important to have conversations with an individual or a practitioner who's knowledgeable about it to see if it will work for you.
That's great. I think we have time for one more. Dr. Lega, what about similarly, a lot of talk of testosterone right now and its benefit for brain health, but also, libido and other areas?
Yes, there's a lot about testosterone. Really, the only clear indication for using testosterone therapy for a menopausal woman is for low libido. That's where the guidelines sit, because that's where there's good evidence. Everything else that's out there is not based on good evidence. In some cases, there is no evidence, right? So there are some claims about, I think, muscle health, there's a little bit of non-evidence, but there are certain conditions, the association with testosterone has not been studied yet. So again, stay tuned. I do think in the future there will be more available research, but right now low libido is the only guideline driven reason to prescribe testosterone.
Yeah, I think that's a real theme in this, is so much more research is required in this area. We know so very little. Thank you both. That was an absolutely fabulous conversation, and I really want to thank you so much for sharing your expertise and your knowledge. And before we wrap up, we would love to get your feedback. For those of you that are joining live on Zoom, you're going to see a poll question pop up on your screen, and we'd love for you to click the response that best reflects your thoughts. So we'll leave that up for a moment, but if you can't see it or can't access it, don't worry, because we will include the survey link in with the recording and the slides, and we'll be sending all of that to you. It's very important to get your feedback, because that really helps us to consider other topics and continuously improve. All right. Well, tonight perfectly captured what Arthritis Talks is all about, bringing together the best research and practical insight in a supportive community that makes managing arthritis not just possible, but helps us to be empowering. So thank you again to Dr. Lega and Lalitha for sharing their wisdom, and to the Menopause Foundation of Canada for collaborating on the webinar, to our donors who make these vital conversations possible. If you'd like to help bring more programs and resources like Arthritis Talk to Canadians living with arthritis, please consider supporting us. You can text PAIN to 45678, and that will donate $10. Very quick and easy. and every dollar supports research, advocacy, and programs that help people manage pain and stay active and maintain their independence and quality of life. This concludes our 100th Arthritis Talk. Yippee! A wonderful milestone that we've celebrated together. So thank you for joining us and for being part of this community, and we look forward to seeing you soon. Thank you all so much.